Hello, everyone. Hello, everyone, and welcome to today's Journal Club, hosted by the International Society for the Prevention of Child Abuse and Neglect. Our Journal Club monthly webinar series features articles on a variety of topics from our journal, Child Abuse and Neglect, presented by the authors themselves. Today, you will learn about the research of Jill McTavish and Harriet MacMillan of McMaster University on the relationship between child sexual abuse disclosure patterns and post-traumatic stress disorder, or PTSD. The authors will also discuss a related Canadian public health program called Vega, Violence, Evidence, Guidance, Action, which includes guidance for providers on recognizing and responding safely to family violence and CSA. Right now, I have everyone on mute to avoid background noise. We welcome you to enter your questions and comments in the chat box throughout the presentation. The presenters will answer any questions at the end as time permits. Jill McTavish is a postdoctoral fellow in the Offord Center for Child Studies and the Department of Psychiatry and Behavioral Neurosciences at McMaster University. Currently, she is working with Dr. Harriet MacMillan on Vega guidance development, addressing strategies to recognize and respond safely to family violence, including child maltreatment. In this work, Jill has consulted as a technical advisor to the World Health Organization in their child maltreatment guideline development work. Dr. Harriet MacMillan is a psychiatrist and pediatrician who conducts research on family violence. She is a distinguished professor in the departments of psychiatry and behavioral neurosciences and pediatrics at McMaster University. Harriet's research focuses on the epidemiology of violence against children and women. She has led randomized controlled trials evaluating the effectiveness of approaches to preventing child maltreatment and intimate partner violence. Harriet was also the founding director of the Child Advocacy and Assessment Program at McMaster Children's Hospital, and she continues to see patients there, as well as provide consultations to child protection agencies. Jill and Harriet, we thank you very much for being with us today and sharing your insights on this work. Now I will turn it over to you.
Thank you, Heather, for that introduction, and thanks everyone for joining us today. We have some headset things to work out over here. So as soon as I'm done my part of the presentation, we're going to pass it over to Harriet so that she can chat with us a little bit about Vega with us today. So this presentation that we're doing is based from the article in Child Abuse and Neglect, Child Sexual Abuse Disclosure and PTSD. And we have authors Irina and Christine Weckerle who also were involved with us in the paper. So we'd like to thank them for their contributions to the paper, which we'll discuss briefly today before going on to Vega. So we'll start out with what I think many of us know, just a little bit about child sexual abuse, the research on disclosure, and then why we chose to look at post-traumatic stress disorder specifically, what we don't know, so why we wrote this paper thinking about how disclosure influences trauma symptoms specifically for child sexual abuse, and then if you've read the paper, you already know the conclusions of the paper are a bit mixed, but I think that the Vega, which Heather mentioned, Violence, Evidence, Guidance, Action, a public health response to family violence. We talk about some evidence-based education resources for healthcare and social service providers that we're working on here, a pan-Canadian project that's going to be rolled out to all healthcare and social service providers for free. And so these have perhaps more helpful responses than more research is needed, and we'll see when we get there. So just want to start off the presentation today chatting briefly about the UN Convention for the Rights of the Child. I think all of us are familiar with this process or this treaty document, which calls for countries to develop legislations and implement services for the rights of children. So we're obviously operating from the position that we need to protect all children from all forms of violence, from all forms of sexual exploitation and abuse, and from abduction, sale, and trafficking. But I think one article that we're increasingly becoming interested in is Article 12 and the right for children to express their views freely and opportunity to be heard. This is something that I find Harriet and I are thinking a lot about, and I think that child sexual abuse has done, or the field of child sexual abuse has done a good job getting the views and perspectives of children on services they're receiving, and perhaps this is a little bit less so in other forms of maltreatment, but I think this is really important, the hearing from the voices of children as we go along in this research. So child sexual abuse, we know, is the involvement of the child in sexual activity that he or she does not fully comprehend or is unable to give informed consent to. I think we know that this is a prevalent health condition or a prevalent exposure which has many potential negative consequences. Sorry, my screen just froze there. And I think, though, when we hear the definition, what is a little bit less clear is how this shows up in practice. And so we have a case example here for you to consider throughout our presentation in terms of what might look like, what might child sexual abuse look like when it shows up, and then what might our educational resources, the Vega educational resources, need to help providers to better recognize and respond to family violence. So a domestic violence shelter worker observes a 7-year-old boy making action figures do what seems like sexually suggestive acts in a repetitive manner. So some things to consider over the course of the presentation. Is this a sign of child sexual abuse? What might the shelter worker do next? If they're concerned but they don't suspect yet, what questions might they ask? How could they ask those questions safely? What would you do next if you're not a shelter worker, but you're another type of provider that works with children? How does this differ across professions? How does what comes next differ across countries? So we know, I'm thinking here specifically about mandatory reporting legislations that we have in Canada, and they differ depending on the country you're within, but then also the different services that we might have across countries and what might be the next steps. So this is a little bit about disclosure, don't tell, and then when they do tell, how do they tell? We know there's a lot in the literature about fear and how children don't tell because of the consequences of telling to their families, potentially to the person who's abusing them. If they're of an age to consider the stigma associated with child sexual abuse, the fear of the stigma as well. They may be coerced or threatened, and we know in the literature that being threatened is associated with trauma symptoms. There may be communication difficulties that may be a sign of child sexual abuse, or the communication difficulties may have come before an exposure, or it may be that they don't speak the language of the person that they're speaking with, the provider, for example. So there's lots of reasons why children don't tell us what's going on. I think there's even more examples of this in the literature. And then how do children tell when they tell us? They might tell us gradually over time. In some of the papers that we reviewed, adults who came into the studies, we reviewed both children and adults. Adults had not told before the time of the studies, so they might never tell, or they might tell in their childhood, or they might tell in their adolescence or university. They might tell spontaneously. There's lots of accounts in the literature of children who something's going on at school with their teacher, and their teacher is talking about something, and then the children tell spontaneously without meaning to, and then worry about their safety for the rest of the day and what's going to happen now that I've said this. So obviously, children's feelings and sometimes their trauma symptoms can be linked to their disclosures and how they're feeling about these things at the time. It may be intentional or unintentional. And then often children tell us through their behaviors. And so this is something we see in the literature, and Harriet, as a pediatrician and psychiatrist, might see more clinically. But for example, the National Institute of Health and Care Excellence has over 70 indicators of child maltreatment, including child sexual abuse, that we can be alert to as providers. And we can think back to the case example, and it has some more clear indicators for us to consider whether or not this might be a case of child sexual abuse potentially. So I'm mentioning here the International Classification of Diseases definition, ICD-10 definition of PTSD, and I don't want to start a controversial conversation about this. I'm not sure that I'm the best person to answer it, but I know, for example, there's lots of research right now about the ICD-11 and how the definition's a bit more narrow, and how less people are going to be classified as having post-traumatic stress disorder symptoms, and potentially less people getting services. So there's lots being written about that right now. But I just wanted to mention here that we chose post-traumatic stress disorder to think about in relationship to child sexual abuse and disclosure, given that it's a common developmental outcome from child sexual abuse. Obviously, not all children who have the experience of child sexual abuse go on to have post-traumatic stress disorder symptoms, but it is a significant outcome to consider. And so that's why we chose it. And when we were choosing the papers, we considered any measure, any definition of post-traumatic stress and disorder. And just a reminder that PTSD is one of many common trauma responses to child sexual abuse, and we didn't review them all, and perhaps our inconclusive findings from the paper, because you need to consider a lot more outcomes than one. For example, a lot of the papers that we reviewed also looked at depression as an outcome from child sexual abuse. So something for any of you who are systematic reviewers out there, that might be a nice paper to consider in the future. So, child sexual abuse disclosure and PTSD, how do they relate? This was the question that we were seeking to answer in the paper that we are looking at today. We did a systematic and critical review. We looked at 5 databases, systematic search across 5 databases, double independent screening of title and abstracts, critical appraisal of all the studies. We did a number of calculations, which you can look at in the paper, different calculations for if there was PTSD diagnosis or symptoms, or if studies only reported correlations. We were more interested in how all the pieces fit together, so we never set out to do a meta-analysis, but even after our review is over, I'm not sure that the set of studies that are out that are available would be suited to a meta-analysis, so that's something to keep in mind as well. And although theories are a bit dry to talk about, I think that it's important for us to just pause and think about the way that people are thinking about the connection between child sexual abuse disclosure and PTSD in the papers, because I think this will really help us think about a way forward, what we might do afterwards. So a lot of papers talked about the socio-ecological theory and the complex, how trauma responses are related to a complex interplay of factors related to the person. So their gender, their coping styles, their exposure, different severity or chronicity of the exposure, the microsystem, so how their family support or how family reactions to disclosure happened, the mesoexosystem support, so what kind of formal support systems did they have, macrosystems, what kind of societal or cultural conceptions were impacting recovery, such as rape myths, chronosystem, was this a kind of experience of violence that occurred in a larger experience of violence in the home? Did this experience of violence then lead to dating violence or violence later in adulthood? So the socio-ecological theory doesn't have a lot to say about disclosure per se. It talks more about, for example, the microsystem responses to disclosure, so reactions that families and friends might have, but it reminds us that the process is very complex and that there's lots of factors that are going into why someone might have a trauma response and why another person might not. Emotion inhibition theory, this is James Pennebaker's work, and I think that this theory was mentioned the most by papers in passing. And I think it's really important to bring up because there was this general assumption in the paper that disclosure was necessarily a positive thing. And I think that potentially for child sexual abuse, it's a bit more complicated. So emotion inhibition theory by James Pennebaker suggests that physical and mental health improvement following writing, they were specifically looking at writing, may develop as the person develops mastery over characteristics of the trauma event. Well, that was how they conceptualized what was happening later on in their research. But I think given the mixed findings of the paper, and I think, speaking to clinicians about the results of the paper, it's not surprising that it's a bit more complicated than that. And then Emotion processing theory, this is the big one, the classic one, underlying a lot of the exposure therapies that we see having a lot of success, at least for adults with PTSD, but increasingly there's research in adolescents as well by Edna Foe and colleagues. Just the idea that PTSD emerges from these large fear structures that are related to traumatic events. And what I think is helpful about their theory is that they have some account for disclosure and why PTSD might not result for some people. So they talk about how people might naturally extinguish these fear structures by emotionally processing trauma material in their everyday life through repeated disclosures about their trauma or through confronting situations that remind them of their trauma. So they have a little bit in there about what might be happening, why some people might not have PTSD result from these experiences. And then, although it wasn't mentioned by other, although none of the papers talked about theories of disclosure specifically from other disciplines, I just want to mention that, for example, there's disclosure decision-making models when thinking about why someone might make an HIV disclosure or why someone with infertility might make a disclosure that we might want to think about. And so there's lots of theories out there that talk about a complex interplay of factors that are just related to the decision-making related to disclosure. So hopefully, although theories are a bit dry, we can use them to think about the results of this paper, which basically are very inconclusive at this point in time. So there's a number of papers looking at a number of aspects of disclosure, and it's really mixed across the board. For example, papers that looked at disclosure versus no disclosure, 4 papers found lower rates of PTSD in those that disclosed, and 4 found higher rates of PTSD. And when we look at recanted disclosure in children, this is perhaps not surprising from a clinical point of view, but children who had recanted disclosures had higher rates of PTSD than children who did not disclose. And we know, at least from the literature, that recantation is can be a possible concern about safety in the home, something to consider. And then I think short delay and long delay disclosure, it's interesting for those who are interested in the more research side of things, why less than a month was chosen. It seems to be a bit arbitrary, but potentially combining the short delay and the long delay disclosure, we can see a very, it's a very weak trend towards either short delay or long delay disclosure having lower PTSD symptoms than if there was no disclosure at all, but not very conclusive at this point. And then there's a couple of papers that looked at things like disclosure to mother versus someone else. The paper looking at adolescents showed that children who disclosed to their mother had lower rates of PTSD than those who did not, whereas the paper in adults suggested that adults who disclosed to their mother had higher rates slightly than those who disclosed to someone else. So obviously thinking through what's happening for children and adults is a bit different, but then also thinking, it's more potentially complex than if you're disclosing to your mother or not, what makes a home environment a space where disclosures can happen. And then negative reactions to disclosure, although there was a number of papers looking at reactions to disclosure, all had kind of inconclusive findings. There was 5 papers, again, very weak trend towards negative reactions to disclosure having higher rates of PTSD than those who did not experience negative reactions to disclosure. So what does this mean for us at doing this review? We could stay the standard clause that more research is needed for those of us who are thinking about this. But I think based on the theories that we're looking at, maybe one thing to consider is that beyond disclosure for concerns of immediate safety, so ensuring that child sexual abuse stops or making a movement towards that, disclosure may not always benefit children or adults with experience of child sexual abuse. It may be more complex than that. It has more to do with thinking back to the social ecological theory, safety in the home more generally, services that may or may not be provided, support and so forth. And so I think that the equation disclosure is positive is a bit too simplistic potentially, although I would be happy for people to do research and find that I'm wrong in that regard. And I think another thing that this says also is that responses to disclosure can be made more safe. And I just want to draw attention to the World Health Organization clinical guidelines, because I think that they have some great initial work on how one can make, as a provider, one can make responses to disclosure more safe. And I think, now I'm going to pass the headset over to Harriet. That's one thing that we're really concerned about in this project that we've been involved in, these educational resources, is how we can make responses more safe for children. So I'm going to pass it over to Harriet now.
Hi, everyone, and I'd like to welcome you also and say thanks for the opportunity to speak with you about Vega, which, as you can see on the slide, stands for Violence, Evidence, Guidance, Action. The Vega project has been underway since 2014 and involves a large group of people. We have clinicians, policymakers, and a range of individuals, including students who've participated in this project. I would like to acknowledge Nadine Wathen, who is the co-lead of the Vega project. Nadine is from Western University in London, Ontario, Canada. And also the Public Health Agency of Canada, who has provided funding for this project. Now, the reason that Jill and I thought it would hopefully be helpful to speak about Vega in follow-up to the discussion about this article is really around addressing, given these results, and as Jill said earlier, not simply just going away with, well, more research is needed, what do? We thought we would talk about what we've been doing with the Vega project and what we hope it will provide people in the future. So why did this project come into being? There was a real recognition of the need for an evidence-based response from healthcare and social service providers. So speaking as a clinician, I'm very familiar with the fact that many of my colleagues feel that they really haven't had much training or opportunity to learn about what do you do when someone presents and they have certain signs and symptoms and you want to ask them about exposure to some type of family violence. And I should say that Vega focuses on specific types of family violence, which I'll speak about in a minute. But we're also hoping that what I'm discussing is relevant to the recognition and response to any type of violence that social service providers and healthcare providers may be in the position of assisting people with. So again, just to underscore that there are lots of barriers to people recognizing and responding to family violence. As you can see the examples on the slides, people indicate they're too busy, they haven't had training, there's not the appropriate setting for this to occur. So these are some of the issues that Vega tries to address. And with regard to the types of family violence that Vega is focused on, it really prioritizes how we can respond to child maltreatment, including physical abuse, sexual abuse, emotional abuse, neglect, as well as exposure to intimate partner violence in childhood, and as well intimate partner violence. Now, There are other types of family violence, for example, certainly abuse of older persons, or what is sometimes referred to as elder abuse. But in terms of what the Public Health Agency of Canada wanted Vega to address, it is focused on child maltreatment and intimate partner violence, as well as children's exposure to intimate partner violence. So, how has Vega been developed? We've had partnerships with a broad range of organizations as outlined on this slide. So the idea is that the educational resources that Vega has worked on developing would be applicable for use by a wide range of providers. And with that in mind, the Public Health Agency of Canada organized involvement from all the organizations listed on this slide. So the idea is that the Vega resources could be used by social workers, physicians, nurses, psychologists, dental hygienists, dentists, and in fact, even beyond these groups, but we had to limit it to a certain number of organizations, and there were representatives from these organizations that came together from the very beginning of Vega and formed what was called the National Guidance and Implementation Committee. So representatives have participated in the Vega project throughout, and they were invited to participate by the Federal Minister of Health. So what I'm going to do is give you additional information about Vega, and you've already heard me talk about child maltreatment, children's exposure to intimate partner violence, as well as intimate partner violence. Now I'm going to talk about how have the educational resources actually been developed, and what do I mean when I say educational resources? So first of all, we wanted to develop guidance as well as various types of tools that would help people recognize and respond to family violence. And we started with a series of systematic evidence reviews. So again, we wanted these resources to be evidence-based, and these then informed the development of the actual guidance, so the recommendations that have arisen from the evidence. And then the resources, which I'm going to spend some additional time talking about. The idea was that certainly we would be clear about what do we know, what don't we know around the evidence, but we wouldn't stop there. We would address the actual how-to question. And I think that's something that all of us face when we're lacking evidence. Obviously, we want to continue to emphasize the need to address important questions in this field, but what do we do in the meantime? So just a little bit more about the process, and you'll see on the left-hand side of your screen a number of acronyms, and I'll just walk you through those. So with regard to the systematic evidence reviews, they were carried out by MERCY, which stands for McMaster Evidence Review Synthesis Center. And these are people who have expertise in doing systematic reviews, and they were at arm's length from the people developing the guidance. And again, this was felt to be important from a methodologic standpoint. Then the ERG stands for Evidence Review Group. So there were actually groups put together for the different types of family violence that Vega is addressing. And then McGrade focuses on how do you actually take the evidence that arises from systematic reviews that has been done by the MERCY group and translate that into recommendations, taking into account issues such as accessibility, equity, these kinds of factors. And then just to underscore that we had in developing the evidence, a very close working relationship with the World Health Organization. So we made available to WHO the systematic evidence reviews that were conducted for Vega, because at the same time, WHO was carrying out the work that was needed for the child sexual abuse guidelines that Jill talked about earlier, and the guidelines on responding to child maltreatment. So again, the idea was that there shouldn't be the need to reinvent the wheel, so to speak, that what Vega was doing would hopefully be useful to WHO, and in turn, Vega would build on the work that WHO had done previously. For example, many of you will be familiar with the guidelines that have been done by WHO on responding to violence against women. So those guidelines were also incorporated into Vega's work. So together with the National Guidance and Implementation Committee, Pan-Canadian guidance was developed. Now, I'm speaking to a group of people from around the world, and obviously the question arises, so if this is Pan-Canadian guidance, how is that relevant to other groups? And just to say that the evidence reviews considered the evidence globally. So there were no restrictions put on the evidence in terms of how that was considered. With regard to how the grade process was used in considering issues like accessibility and equity, certainly that was thought about in relation to Canada specifically, but we hope that the work that has been done, which as Jill said, will be freely available in the near future, that people can then look at it and think about how is it applicable to where you are, where you're located. So just to give you some more specific examples of what the educational resources look like. So this material is all going to be available online. So the guidance that then was the foundation for the development of the educational materials will be available. And then there will be various modules. So for example, there's a Know About Family Violence in Canada. Again, this includes some of the information about prevalence, risk, and protective factors. So although the prevalence, some of that is specific to Canada, certainly the information about risk and protective factors is globally relevant. And then the modules that really focus in on what we think is essential in assisting providers knowing how to work with people across the lifespan in helping them with regard to family violence is the recognizing and responding safely. So a key aspect of Vega is to make sure that we don't do harm. And so there's a module on recognizing and responding safely to child maltreatment, and also on intimate partner violence. And then each of those modules has subsections on children's exposure to intimate partner violence, because we do believe, I mean, certainly in Canada, children's exposure to intimate partner violence is considered a type of child maltreatment. We also feel that those who are working with individuals, adults, for example, who have experienced intimate partner violence, that some of those people have children, and there needs to be consideration of their children's exposure. So we wanted to create educational resources that didn't simply sit on a shelf, and I'll be saying more about that in a moment. But another module that we thought was really crucial to Vega was what we refer to as the Creating Safety module. And this talks about, within Vega, we refer to it as trauma and violence informed care. In other words, how does one emphasize safe interactions with individuals as well as safe environments. So principles such as recognizing that any patient or client who is seen by a provider could have experienced violence in the past or could be experiencing it presently, and making sure that the system doesn't re-traumatize the individual. Now, many of you will be familiar with the concept of trauma-informed care, and in Vega, we wanted to emphasize trauma and violence-informed care because, again, this is meant for a broad audience of providers, and even the word trauma can be challenging in terms of what do we mean by trauma? Are we talking about trauma in relationship to some kind of maltreatment, or, for example, a motor vehicle incident? And in this case, we're talking about it obviously in terms of violence. So how did we develop these modules? Certainly there is various information, text available online, but we've also tried to make it interactive and include how-to videos, so actually showing a video of how would you ask a patient or client about some type of violence. And then we include knowledge checks. There's also a handbook which really tries to bring together a summary of the information that's included in the modules. And then we have simulated game scenarios, which we hope will assist with the interactivity. So what I'm going to do is give you some examples as we go through, but I think, in fact, the video that I'm about to show you will hopefully really bring it to life for you. So this video will summarize much of what I've said already, but doing so with also using what we hope are some helpful visual aids. You're seeing a black screen right now, but we're just going to start the video.
Harriet, the video audio is not coming through.
Okay.
I wonder if you unplug the headset briefly when you show the video, it might.
So Heather, let me just try.
Disease, cancer, and other chronic illnesses.
Yes.
It's not a toxin or a virus or a pollutant. It doesn't discriminate. It can affect every.
Hi, I'm Maria. I'm a family doc. I think I'm pretty compassionate. You know, I read the literature and keep up with what's new and the best practices for my patients.
And I'm Mark. I'm a social worker. It's important to support my clients and advocate for their needs. That's why I was so surprised when I became more aware of the huge impact of this one exposure. This kind of exposure is linked to all kinds of mental and physical health problems like depression, anxiety, alcohol, and drug use.
In children, it can affect how brains grow and develop and can lead to all types of problems across their lifespan. In adults, it actually increases the chances of heart disease, cancer, and other chronic illnesses.
It's not a toxin or a virus or a pollutant. It doesn't discriminate. It can affect everybody across all cultures, communities, and income brackets. The kind of exposure we're talking about is family violence. Family violence is a complex issue, and every Canadian family is susceptible. The numbers are staggering. About 1 in 3 Canadians has experienced abuse before the age of 15. A Canadian woman is killed about every 6 days by her current or former partner. We're becoming more aware that men are at risk as well. Transgender people have much higher rates. Over 60% reporting experiences of intimate partner violence, or IPV. You may know IPV as domestic abuse or domestic violence.
There are lots of different words used to describe family violence. With children, it's often called child abuse and neglect or child maltreatment. Another type of family violence is called children's exposure to IPV and involves a child hearing or seeing violence among caregivers or being aware of its effects without actually witnessing it.
Whatever you call it, Research shows that physical, emotional, or sexual abuse and neglect can impact all aspects of a person's life, including how they learn, speak, behave, and interact with others.
When I read about family violence, I realized there was more to it, and I really needed to learn a bit more about this. I found a great resource called the Vega Project. Vega has created evidence-based guidance, a handbook, and innovative educational resources about recognizing and responding safely to family violence. It's the first time that national organizations, including nurses, dentists and dental hygienists, doctors, child welfare advocates, and a range of others, have come together to develop ways of helping people know how and what to say and do to help patients experiencing family violence. Also, what not to do. This type of violence is not always obvious. In fact, it's often hidden. Most importantly, I don't want to do more harm. To be honest, I didn't see this as part of my role. I basically viewed family violence as a personal or social issue best addressed with a referral to someone else. Obviously, if there was a disclosure of violence, I would address it, or if it was a child protection issue, I would report it. But in terms of my patient's own personal medical history, I didn't consider how these experiences of family violence could impact their health.
I know what you mean. Although I learned about family violence in my training, I didn't learn about the widespread health impacts or how best to respond. Vega has developed guidance so we can better navigate family violence and how it affects our clients and or patients. It makes me better at what I do.
Exactly. When I didn't consider how family violence influences disease and behavior, it prevented me from effectively communicating with my patients. Now that I really think about it, maybe I avoided bringing these sorts of things up because I didn't want to make it worse or shed light on an issue I couldn't handle. I didn't know how to make it safe to address family violence in my day-to-day practice.
The Vega Project developed an approach called Recognizing and Responding Safely to Family Violence, which addresses those exact concerns. Now, I feel like I know what I'm doing. I'm less worried about causing harm. And you know what? This is relevant to all my clients, not just those affected by family violence.
Very true. It makes me think more carefully about the cases I find challenging. I used to ask myself, why would someone act like this? Now I try to be more compassionate. So instead of wondering what's wrong with this person, I think about what's happened to this person and start the conversation there. Vega's handbook helped me to respond to my patients, and now I understand how important it is to create both a physically and emotionally safe environment.
It's encouraging, right? And new evidence is emerging about promising interventions that can help both adults and children address the impacts of violence.
Knowing how to recognize and respond safely and what the appropriate referral pathways are creates a better experience for all of us. When this becomes a part of your everyday practice, your patients are more likely to benefit.
To make this part of your practice, start by looking up projectvega.ca. There you can find tips and tools like how to recognize the possible signs of abuse and ways of responding safely. Practical, evidence-based guidance.
The Vega Project is available to educate and support us to work safely and effectively with those impacted by family violence. Vega helps us provide the best possible care for our patients and clients.
So thanks, everyone. Sorry about that little glitch with the audio. And Heather, I'll just check with you now that I'm back on the headset that you can hear me.
Yes, sounds great.
Okay. So, and I should just start off by saying that Vega will be available to everyone after it's publicly launched, which will happen sometime, we're expecting, in either December or at the latest January 2020, but we're hoping in 2019. So whereas the video says go and get these resources now, they're not yet available. They're just continuing to be tweaked, as we say, and as well, they're being translated into French. So they will be available in English and French. So stay tuned. And again, we will make sure to let everyone know when the Vega materials are available. But let me just quickly tell you a little bit more about what's to come. and the type of materials that Vega includes. So there are, as I said before, what we refer to as how-to videos. So how do you actually ask about child maltreatment? So the slide in front of you, Bodhi Akinton is a child psychiatrist, and it shows Bodhi asking a patient who's been having some difficulties how do you actually include questions in this case about types of maltreatment? And specifically, Bodhi ends up eliciting information that leads him to suspect child sexual abuse. And then another question that people had talked about as being important to address with Vega, how do you tell a family that you need to report to Child Protection Services? We know that, again, from the literature, that families do best when they're advised as much as possible about what's going to happen. And so we have a video that shows this type of discussion. And again, what we tried to do along with our National Guidance and Implementation Committee is identify what are the questions that providers find so difficult, how to do this in a way that is respectful of children and families, and above all else, trying to minimize harm. This shows you an example of some of the material that's in the handbook. So again, the handbook provides an online summary of the materials from the modules. The modules are interactive. That's where the materials such as the video and knowledge checks exist. And then the handbook brings it all together. And this shows an example of a child maltreatment care pathway and the various elements that are outlined in the handbook. And here's an example of the type of guidance. So you'll remember the guidance is based on the systematic evidence reviews. And so here we talk about the fact that health and social service providers need to ask about child maltreatment when potential indicators are present, and we list what some of those potential indicators are. But we also emphasize that there is no evidence for universal screening of child maltreatment. So this shows you how the guidance is captured within Vega. And again, for this particular presentation, we're focusing on the elements of Vega that pertain to child maltreatment, but all of the examples that I'm giving you also have comparable materials in the area of intimate partner violence. And this shows you the type of game scenario. So again, interactive. This shows a mother bringing a child into a clinic setting, and the child has a bruise, might be hard to see, but in the his upper right forehead. And then you can make various choices and you get feedback about the choices that you select. And we think that Vega will be useful for students, for a variety of trainees, as well as for those in practice. Because again, at least what we're hearing from people in Canada, there hasn't been the opportunity to learn about this type of very practical information. So that really gives you a snapshot of what Vega is all about. Again, even though you can go to the website and see what's to come, the actual educational resources won't be available for a few months, but we are very excited that they are forthcoming. And we hope that discussing Vega along with the information that Jill presented gives a sense of, well, while we're waiting for more research on issues such as disclosure and PTSD, these are some materials that can hopefully help our patients and clients, and at the very least, not do harm. So thank you. I'll stop there. And Heather, I know that you've been looking at potential questions that are coming in.
Yes, thank you so much, Jill and Harriet, for being with us today and for sharing your insights on this work. There are a few questions. Hold on one second while I switch the screen. Okay, great. So we have several questions related to Vega and just a couple related to Jill's presentation on the article. So going back to Jill, we had a question about, sorry, are you switched over?
Oh, yeah, just switched over.
Hi. So a question about perpetrators of violence. This attendee asks, does who committed the violence against the child impact the end result, positive or negative, of the disclosure? For example, whether the perpetrator was a stranger versus someone connected to the child and or their family.
I'm trying to recall if there was any mention of that specifically in the paper that, and nothing's coming to mind.
Okay.
It makes sense to me that there would be a difference because when the violence is happening potentially in the home, there's more of a potential for disruption, you know, to the family life, and then the person you're seeing, there's more of a safety issue there. But I don't recall anyone splitting the evidence by that, but I can get back to that person. You can give me their name, and if I find it, I will get back to them.
Okay. All right.
Apologies
that sounds good.
that I don't think so.
No problem. Okay, so then I think most of the other questions are more about Vega. Let's see. Let me start. Hold on one second. So currently Vega is going to be provided online. Do you see down the road that it could be adapted for in-person training? Is that a goal of this? And how are you going to, how will it be kind of distributed or disseminated or promoted to these providers?
Okay, I'm going to pass that to Harriet. So Harriet, the question is, right now it's online training. Will there be a chance for in-person training? And if so, what will that look like? How will it be distributed?
Okay, and yes, if you can picture this, Jill and I have one headset between the two of us, so we do apologize about that. You know, I think we really want to hear from everybody how you think Vega can be useful. So, you know, basically there will be the online educational resources available, and the hope is that, for example, those of you who are teaching and training will incorporate Vega into those types of activities. You know, if we were to hear from people, you know, we'd really like to have something available with Vega where there's an in-person opportunity for that, then that's certainly something that we could look at. We first wanted to make sure that we developed all these materials such that it could address the recognizing and responding safely and facilitate the kind of training that was identified as lacking across so many types of educational programs. So I guess the short answer is not yet, but possible.
Okay, great. Another attendee wondered if the project will include a module around corporal punishment.
Very interesting question. So the module or the modules at this point don't specifically include corporal punishment, but certainly that's something that could be to Vega. And, you know, one of the issues is, as we hear from people what's missing, that again can direct what happens with Vega in the future. So I didn't talk about some of the feedback loops that we have used with Vega, but Vega has undergone a lot of testing, looking at the various modules with students, providers, and what's going to happen down the road once there's the public launch is there will be further evaluation, and I could imagine that developing a module on something like corporal punishment would be really important. So I appreciate that question, and I think it's a good suggestion.
Okay, great. So this attendee is wondering about situations where children do not present with obvious bruises or physical abuse, and how you get the disclosure from the child with the parents being in the room.
Yes, well, and these are exactly some of the dilemmas that we hope Vega begins to address. And I say begins because we really feel that the best way to learn about some of these responses is to use the online resources, but also role playing, and then making sure that there's appropriate and adequate supervision for learners when they're actually interacting with patients and clients. So we do have videos that address the issue of how does a provider indicate to parents that they need to see a child separately. And we have videos that show asking questions related to emotional abuse. I already referred to sexual abuse, certainly physical abuse, neglect, and children's exposure to intimate partner violence. So all those types of maltreatment do have what we refer to as how-to videos included in Vega. The other thing is we've tried to keep them short, and you know, you heard Jill say earlier that disclosure can be a process, but what we've tried to do is to create videos that demonstrate principles, recognizing that they need to be coupled with, again, the role playing and further discussion about clinical cases.
Okay. And as you noted, we do have an international audience listening. And so do you, what do you think about the content and its adaptability for different countries and contexts? I mean, can the content be translated or modified in any way for different cultural situations?
So I would really look to the audiences, you know, across different countries to let us know what they think, because you know, we've tried to be very careful as we put together the information to make it as generalizable as possible. We also appreciate, and I've had discussions with folks about the fact that, you know, when it comes to videos, that people like to see examples that are very specific to their location or their profession. So, you know, I think the the most important thing is to find out from people out there, when Vega becomes publicly available, how generalizable do you think it is? How helpful do you think it is? We've tried to make it helpful. I mean, obviously, the Public Health Agency of Canada wanted to make sure that we address the needs of people in Canada, but we've also tried to structure it such that it will be useful beyond Canada and in other areas.
Okay, great. And then just to clarify, this will be online and it will be free for the public?
Absolutely, yep. So what will happen, when people want to use it individually, they'll just be able to go in, and we do collect or will be collecting a little bit of information, you know, such as you know, where people are from, just so we can keep track of this. Let's say an organization or a particular agency wants to use Vega, then we will ask them to apply for what's called a user's license. It doesn't cost anything, it won't be difficult. It's really just to keep track of who's using what, and it will be entirely free. And that's something I really want to emphasize. We want Vega to be out there and to be used, and we want to hear from people how useful they think it is, and you know, how it can be adapted to particular needs.
Okay, great. So we will be looking for this. You said December or January 2020?
Yes. In Canada, we have a federal election coming in October, and you can imagine that when a federal agency is involved in a launch down the road, we need to have that happen after the election. So it takes some time to get organized, and as well, we need to make sure that the French translation is done. So those are the factors that are making it a little bit challenging to say it's being launched on this particular date, but you know, that's what we're aiming for. December, hopefully, ideally, and if not, early in the new year.
Okay, great. Well, we are about at time, so I want to say thank you again to Jill and Harriet for sharing this information with us today. And thank you everyone for your questions and for joining us. A recording of this webinar and a PDF version of the slides will be available within 24 hours on the ISPAN website. We encourage you to become a member of ISPAN so that we can continue having informational webinars like these in the future. If you're interested in presenting or have ideas for topics for our webinar series, please contact us at resources@ispan.org. Thank you all again for your time today, and we hope you have a good day or night, depending on where you are. Thank you, Jill and Harriet.
And on behalf of Jill, because again, we've just got one headset, it's Harriet, I'd like to say thanks to all of you for attending, and don't hesitate to be in touch. We'd love to hear your thoughts and any additional questions.
Okay, great. All right, thank you everyone. Bye-bye.
Bye.